Okay, it's 12 o'clock, so I think we will go ahead and get started. Welcome everyone to our master's essays. This is the first week where we get to hear our presentations from our second year master's students. And so thanks to everyone who is going first. I know that it's a little nerve-wracking to be the first ones. So we have 4 presentations today. Each presentation will be about 10 minutes, which will allow 5 minutes for questions and answers. I will be timing the speakers, and so if you kind of are going over a little bit too long, I might jump in, but I'll give you a little bit of leeway if you're wrapping up around the 10-minute mark. So we're going to get started. Our first presentation is from Sahana Shekhar. Sahana has a Bachelor's of Arts in Cell Biology and Neuroscience from Rutgers in New Jersey, and the title of her presentation is a qualitative exploration of community health workers' perceptions of antenatal psychological well-being. She was able to do this work in India, so I'll let her tell you all a little bit more about it. So go ahead and get started, Sahana.
Hi, everyone. Can you see my screen okay?
Yes,
Wonderful.
we can.
Okay. Good afternoon. My name is Sahana Shekhar, and today I will be presenting on my work titled A Qualitative Exploration of Community Health Workers' Perceptions of Antenatal Psychosocial Wellbeing in Kunigal in the state of Karnataka in India. And so I would just like to speak a few words on my motivation to join this project. And so here is my mother in 2001 in front of our home in New Jersey when she was pregnant with me. We were very fortunate in that her parents, my grandparents, were able to stay with my parents to support them through the pregnancy and a few months after. So when I was presented with the opportunity to understand these experiences of social and emotional health during pregnancy through community care in India, I was very interested, and I'm excited to share this journey with you today. And so here is a brief overview of what I will be going through during this presentation. A little bit of a background on the study. The World Health Organization describes maternal health as a state of well-being in which a mother realizes her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her community. And I think this definition speaks to how important it is to look at well-being during pregnancy, beyond just the absence of illness, and really into mental and emotional developments during this transitional period. And so in low and middle income countries, an estimated 15.6% of women experience antenatal anxiety and depression, which rises to 19.8% during the postpartum period, calling for early mental health interventions. And so within the Indian context, this prevalence of antenatal depression is at about 20%, and there are various predictive factors which can go from unplanned pregnancies to multiple pregnancies, lower educational attainment, and lower socioeconomic status. And so within this context, the community health worker models have been established as effective systems to expand evidence-based treatments and practices to these underserved communities. And this extends to mental health as well. And so this qualitative study looked at 2 research questions. The first one was the community health workers' perceptions of antenatal mental health or psychosocial well-being among the pregnant women in the area. And the second one looked at how these perceptions shape the health workers' delivery of antenatal mental health care services within the current maternal, neonatal, and child health or MNCH delivery system. And so for the methods of this study, the study population consisted of community health workers who received training in both antenatal and postpartum care in Kunigal. And the eligibility for the study included a minimum of 2 years of experience as a community health worker and a population coverage of at least 800 community members. And out of this study population, we created an analytic sample of 19 randomly selected CHWs who were screened for eligibility and included in the study. And some sample characteristics, the community health workers had completed education levels of 10 to or the 12th grade, covered a population of about 900 to 1,200 community members, and had at least 3 years of work experience. In terms of the data collection, the primary study tool used was in-depth interviews, or IDIs, and these were pre-tested semi-structured interview guides that mainly looked at CHW knowledge and perceptions on antenatal mental health, as well as how the CHWs perceive their roles as healthcare providers in the community. And these were audio recorded, translated from Kannada, the local language, to English, transcribed verbatim. We developed a deductive code book, which was followed by inductive open coding done by 2 independent researchers, and a code quote matrix that was developed to explore broader emergent themes. And so here are the three themes that I will go into in a little bit more detail. The first one essentially explored perceived differences between mental health as a protective factor and mental illness as a risk factor. And interestingly, the community health workers sort of related the term psychosocial well-being to adverse mental health, citing specific severe behaviors that were associated with depression or anxiety. And you can see that as one community health worker conceptualized in the quote below. Mental health means if someone has any problem, then that person will be getting pulled down by his own thoughts. Additionally, community health workers identified antenatal mental health as a precursor to positive physical and social health behaviors, and they also centered antenatal mental health as a priority for infant and child health. And the second theme looked at factors implicated in stress, worry, and fear during pregnancy. And if this diagram seems familiar to all my PFRH folks, it's because it's the Bronfenbrenner socio-ecological systems model, which essentially was originally developed for child health development, but can be extended to antenatal and maternal health settings. And so some individual factors involved internalizing social expectations, as well as the stress of early conception following marriage. The relationship dynamics within the family were also cited as very important, particularly how husbands and mothers-in-law cared for the pregnant women during that period. When it came to community involvement, there was a risk and protective duality. So positive relationships with neighbors was protective, and speaking negatively about pregnant women led to social anxiety. And finally, at the macro system level, there were different sociocultural ideations. And so there was a severe preference for male children. And so anticipation of that led to significant stresses, changing gender roles where women had to balance working outside as well as domestic responsibilities. And finally, a community-based stigma against mental health, where that delayed care seeking at times. And the final theme was involving community health worker antenatal mental health care provision. And so if you can see within this pyramid here, a foundational base of adapting care to address community stigma was very important for the community health workers, which was followed by providing advice or lay counseling to both individuals and families on protective behaviors, which was followed by building trust and resilience between the community health workers and pregnant women to ultimately increase service utilization. And so here are some key takeaways that essentially map the findings to our original research questions. You can see interconnectedness with the environment, relating to family dynamics, providing care along the maternal and neonatal child healthcare continuum, placing antenatal mental health at the center, and modifying family and social environments, and finally building resilience and strengthening support. Some strengths and limitations of the study. There were key insights from the study on community health worker perceptions on antenatal mental health care specifically, as well as strong methods of data collection and analysis. Some limitations, however, were that we only collected data on the years of work experience and education levels for the community health workers. There might have been potential researcher biases while sorting the data, and participant biases in terms of responses, and lower generalizability to the larger CHW population by the nation. And finally, some future directions. We hope to publish these findings and hope that this study gets conducted across similar settings to improve generalizability, into programmatic changes by mobilizing local resources to increase funding, recruitment of community health workers, and finally, preparing policy briefs that cater to state governments to increase implementation of antenatal mental health services across various blocks in Karnataka, India. And here are my references. I would like to give a big thanks to the community health workers that I worked with during my field placement, my mentors and colleagues at the organization, Karnataka Health Promotion Trust, my primary reader, Dr. Celia Karp, who helped me conceptualize this, PFRH staff and faculty for giving me key public health practice insights, and finally, my family, friends, and cohort members for all their support. Thank you.
Really nice job, Sahana, and you're right on time, so that's great. So we have a few minutes for questions. Does anyone have a question about Sahana's presentation? Great. Yeah, Celia, I agree with Celia. Great way to kick us off today. I just have a quick question, and I apologize if I missed it, but were the community health workers trained to address mental health issues specifically? I know they do a lot of different things in their roles.
Yes, that's a great question. So they don't receive formal mental health training. They do sort of, or they're kind of primed to identify adverse mental health adverse mental health condition signs, like, being socially withdrawn or neglecting care seeking, which is why some programmatic changes would be, strengthening formal training.
Mm-hmm.
That's a good question. Thank you.
That makes sense. Does anyone else have a question for Sahana? And so I guess I'll ask one more question since everybody's nervous to get started, I guess, with questions. But so was this your first time doing qualitative research, or is this something you've done before?
So this was my absolute first time doing qualitative research. When I went into the field placement, I was actually preparing for a quantitative study, but that project got changed. So it was an amazing learning experience, very much on the job. And yeah, I'm very, very grateful for it. So and I was very grateful that I got to interview the community health workers in the local language. So it was truly an amazing experience for me. My family is from the state, a different region, but yeah, a lot of personal growth as well.
That's fantastic. Yeah, to be able to speak the language and to get that context and build that rapport must have been fantastic. Fantastic experience. Wonderful. Any final questions for Sahana? All right, you did a really great job with your presentation, really important findings. And so thank you so much for kicking us off. All right, so our next presenter is Mairead. So good job, Sahana. So there we go. All right, Mairead Minihane is, we were chatting about Irish names in the chat. So I hope that I did a good job, Mairead, with your name. She has a Bachelor's of Science in Human Development from UC Davis. And her research project is focusing on expanding mothers and babies to birthing hospitals with doula services in Maryland. So Mairead, go ahead and get started.
Great, thank you, Erin. Yeah, so today I'm going to be talking about my research proposal for expanding mothers and babies to birthing hospitals with doula services in Maryland. My name is Mairead Minihane. I do have one of the complicated Irish names, and my reader was Dr. Elizabeth Sturman. So just an overview of Mothers and Babies. Mothers and Babies is an evidence-based intervention for pregnant individuals and new parents that provides interventions to mitigate stress and prevent postpartum depression. They provide a toolkit to families across the United States that's rooted in non-stigmatizing and easily accessible strategies for improving mood and managing stress. Mothers and Babies focuses on promoting engagement, enjoyable activities, healthier thought processes through cognitive behavioral therapy, and promoting social support. So just some definitions to get us all grounded. So doulas are trained professionals who provide continuous physical, emotional, and informational support to their clients before, during, and/or shortly after childbirth to help them achieve the healthiest, most satisfying experience possible. And then perinatal depression, it's classified as the persistent feeling of loss of interest and sadness that occurs after pregnancy or during. And perinatal depression is a mood disorder that occurs within 4 weeks post childbirth and up to 1 year postpartum, with lasting health effects on the birthing individual and their child's cognitive and emotional development. So the burden of perinatal mental health conditions in the United States is significant, with studies finding 1 in 5 women experiencing depression and/or anxiety during pregnancy or the postpartum period. Perinatal mental health conditions are among the most common conditions and often underdiagnosed, with approximately 800,000 people affected each year in the United States. Despite recognition of perinatal depression's impact, significant gaps remain in Maryland's maternal mental health services, especially communities where access to specialized mental health providers is limited, such as rural or underserved populations. So expanding to preventative interventions such as mothers and babies is essential, as many individuals experience increased stress and heightened risk for depression and/or anxiety during this perinatal timeframe. So some specific aims. So this study aims to systematically adopt the evidence-based Mothers and Babies program that seeks to prevent perinatal depression among pregnant and parenting people. The Maryland Maternal Health Innovation Program will adapt implementations to expand the reach and effectiveness of the program to be conducted within the hospital-based doula care programs. The adaptation intervention will address the critical need for accessible perinatal mental health support while leveraging the existing doula care relationships. The rationale for this proposal is to identify effective training models to expand mothers and babies to birthing hospitals that provide doula care within Maryland. The 3 aims of this research are, first, to evaluate feasibility of expanding mothers and babies to doulas. The second is to evaluate adaptation needs for providing doula care within the Maryland birthing hospitals using a mixed methods to identify actual adaptations of mothers and babies to expand to other provider groups. And then lastly, systematically adopt the Mothers and Babies program to hospital-based doula cares using an adapted framework through engagement with pregnant and recently pregnant individuals, doulas, and hospital staff. And then regarding innovation, so this is the first systematic adaptation of evidence-based mothers and babies programs for hospital-based doula care within Maryland. While mothers and babies is traditionally been limited to clinics and community-based providers, the study would expand on its reach into hospital settings. So by investigating the underlying mechanisms and contextual factors that influence the successful implementation of mothers and babies, this research aims to create a more adaptable and accessible version So the focus on hospital-based doula cares represents an innovation expansion of mothers and babies beyond the current provider groups, while opening new possibilities for maternal mental health support in Maryland. So this approach capitalizes on the rapidly growing doula workforce, a resource for mental health innovation delivery that has shown increasing professional recognition and integration into maternal care systems. By leveraging this expanding workforce of doulas, it creates sustainable pathways for scaling up evidence-based mental health support while strengthening the professional capacity of doulas serving vulnerable populations. In regards to the approach of adapting mothers and babies, it will use the ADAPT-IT framework, which is assessment, decision, administration, production, topical experts, and integration framework. So this models an 8-step framework for adapting existing evidence-based interventions without competing or contradicting the core elements. So starting out on phase 1, which is the assessment and preparation phase. In the assessment, the goal will be to obtain an understanding of the target population. So semi-structured interviews with doulas and supporting hospital staff at the implementation sites will be conducted to better understand the current maternal mental health education and specific adaptation needs at their hospitals to support mothers and babies. Next, at the decision level, interventions currently conducted through mothers and babies will be defined and determined to adopt or adapt. Information obtained from interviews with doulas and hospital staff will inform the development of adaptation decision matrices with weighted criteria for each program component. And at the administration phase, it will use existing data to inform adaptation parameters. And then next, moving on to phase 2, which is the adaptation development. So in production, doula training curriculum, implementation guides, and documentation tools will be developed. Additionally, at the stage, researchers will adapt the mothers and babies facilitator handbooks and participant handbooks for the hospital setting. And then at the topical experts levels, so doulas and healthcare providers will be the experts that will review the adapted materials and provide any feedback by completing a short red cap survey. And then integration, so at this stage, development for protocols for hospital integrations will be done. So workflows and structure of doula delivery will be defined, and clear guidelines of role delineation for doulas within the hospital care team will be established, and benchmarks to measure successful incorporation into existing systems. And I added on some future research for the last bit of the ADAPT-IT framework, which is piloting the tested adapted material and training all doulas. So in regards to the methods, the study is a mixed methods formative research study based on the ADAPT-IT framework. The qualitative methods will be to conduct semi-structured interviews. So capturing these qualitative dimensions, we aim to identify both universal adaptation needs and site-specific considerations that inform a contextually appropriate version of mothers and babies to be sustained within diverse hospital settings. The quantitative measures, so acceptability of interventions to measure how agreeable the doulas are with the intervention appropriateness measures to measure how compatible mothers and babies are for hospital settings, and feasibility of intervention measures on how implementation would be. These will be collected via a red cap survey that's distributed by email with unique access links to doulas. So analysis of this red cap survey will provide descriptive statistics that will be established at baseline metrics for the program adaptation and help to identify potential integration points where mental health screening and intervention components could be incorporated into existing doula care workflows. And some potential outcomes. So this formative adaptation research study represents a critical first step in addressing the growing need for accessible maternal health interventions in hospital settings. By systematically adapting mothers and babies program for hospital-based doula care, we establish the foundation for expanding evidence-based mental health support for pregnant and recently pregnant individuals. And then lastly, I just want to give some acknowledgements. So first, I'd like to thank Dr. Sturman, whose guidance, expertise, and support was instrumental throughout this whole research proposal journey. I would also like to thank the research team at MD Mom for their continued support professionally and mentorship over this past year, the PFRH department for their generous academic support throughout this process. And then, of course, my lovely cohort mates for their unwavering encouragement and guidance. Thank you so much for listening to my research proposal today. Any questions?
Excellent job, Mairead. I love this option of being able to do a research proposal. You did a really, really nice job of kind of walking us through each step of it. I think you did a great job. Emmy has a question. Go ahead, Emmy.
This is a little embarrassing because you probably said it at the beginning. You say expanding to doula care hospitals. Is it already in other hospitals? I'm a little confused about the specificity there. And again, I apologize. You probably said this.
No, that's okay. I could have been clearer too. So expanding to birthing hospitals within Maryland. So doulas are already within the hospitals generally. They're in hospitals working with a client that they're with. So this would be going into birthing hospitals that have partnerships with doulas and then trying to work with the doulas who have good relationships. Yeah.
Thank you. Thank you for clarifying. So really interesting. I totally agree with Erin. It's great to be able to do a proposal, and you did a really nice job presenting it.
Thank you. Yeah, this was a great opportunity to practice, and Dr. Sturman was great at kind of guiding me along the proposal.
Great. Did you happen to do a certificate in implementation science through your program?
No.
I was really impressed with your how you walk through implementation and adaptation and the frameworks. I was thinking she must have done an implementation science piece. So you did a great job.
Oh, thank you so much. I'm glad to hear that.
How did you choose the Adapt It framework? I haven't heard of that one.
Yeah, so Beth gave me some good advice of kind of looking into some frameworks, and it took me quite a while to kind of figure out which one would best kind of work for this. And I chose that one because it does allow for adaptations when needed, but you're not forced to make adaptations if it doesn't fit the context that you're trying to do. So I felt it's kind of how I picked it. But there was a lot of frameworks that I was going through in the literature, but yeah, it was mostly just a literature review.
There's a question in the chat.
Yeah, I see that I mentioned perinatal depression can last up to a year. Do you track it beyond that, or is it no longer considered perinatal after that? Someone in the group might be able to answer this as well, but I know it's considered postpartum depression, and postpartum depression can be considered a long-term impact, but it's, I think, only followed for up to a year, and then it could be considered just depression. If anyone else who is an expert in that also wants to jump in, please feel free. Yeah, I see in the comment the Adapt It in the perinatal. I did see it in another class actually come up too.
Great. And do you have plans? Did your organization have plans to submit this proposal in any way?
Hopefully, with the current climate, it has been changing a little bit, but hopefully.
Great. I have time for one more question. Oh, Beth, yeah.
Yeah, if no one else has a question, I had a couple. I told Mairead that I was going to ask her some difficult ones in here. So I'll ask my one kind of challenging, provocative question. So one of the things, with the doula workforce is that it has been getting a lot of attention over the past couple of years, and more folks are wanting to work with doulas because they do such a great service for the community. But as you add different things onto what doulas are already doing, you risk kind of overburdening them. And so I wanted to ask, without necessarily them getting additional compensation. And so I wanted to ask kind of your thoughts on working with this doulas and potentially offering them some additional things they could do with their clients. How would you be thinking about their workload, and also kind of integrating thoughts about fair compensation for them for the additional services they might offer?
Yeah, that's a great question. And I know that kind of when working through this process with the research proposal, we did want to include, or I wanted to include that doulas were fairly compensated for this. And I did look into some of the current kind of government payouts that they're getting, or paybacks that they're getting for the services. And the whole point of this also was to try to integrate it into their clinical workflows that they already have ongoing. So a lot of the questions that I wrote up that I didn't include in this presentation kind of got at how will this be best to be integrated into your current programs to not overwhelm them and adding on too much additional workload to what they already are doing? In regards to compensation, I think that's something we would have to make sure that they're being compensated for. And I know I included in regards to this study, incentives, but I wouldn't want that this program to be added on too much stress that they don't feel they're compensated enough in this type of work.
Great. Thank you again, Mairead. You did a wonderful job with your presentation. So we're going to move on in the interest of time to our third speaker, Aris Stovall. Aris, if you want to share your screen. Great. So Aris has a Bachelor's of Science in Biological Sciences actually, from the University of Maryland, Baltimore County, UMBC, in my hometown. And she'll be presenting today on a secondary data analysis of data from the Pregnancy Risk Assessment Monitoring System, or PRAMS, to measure racism and its relationship to hypertensive disorders of pregnancy in Black women. So go ahead, Aris.
Thank you, Erin. Good afternoon, everyone. As Erin mentioned, my name is Aris Stovall. The title of my presentation is a secondary data analysis of data from the Pregnancy Risk Assessment Monitoring System, or PRAMS, to measure racism and its relationship to hypertensive disorders of pregnancy in Black women. Let's begin. So as a brief overview, I'll provide an introduction and background information, detail my objectives, and share my methods, results, and conclusions. The National High Blood Pressure Working Group on High Blood Pressure in Pregnancy classifies hypertensive disorders of pregnancy into 4 categories: chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and preeclampsia superimposed on chronic hypertension. Each disorder is characterized by high blood pressure, but each are unique in their time of onset and specific symptoms. Risk factors of hypertensive disorders of pregnancy, or HDPs, include race and ethnicity, where 1 in 5 Black pregnancies are affected by HDPs. More specifically, the prevalence of preeclampsia, eclampsia is 60% higher in Black women compared to their white counterparts. Some other risk factors include stress and racial weathering, maternal age, comorbidities, insurance coverage or insurance that may not extend through the postpartum period, and region of delivery. The disparities seen in prevalence of HDPs are consistent with other estimates related to impacts of structural racism, cultural racism, and individual experiences of discrimination among Black Americans. Racism is the risk factor I chose to explore in the study because it influences the compounding effect of the social determinants of health and some of the other risk factors I mentioned above. Despite growing evidence surrounding racism's impact on adverse birth outcomes in Black women, the relationship between experiences of racism and hypertensive disorders of pregnancy in the US have rarely been explored. Existing studies are limited in their hypertension measures and data sample size. So some of the objectives of the study were to evaluate the association between experiences of racism and hypertensive disorders of pregnancy in non-Hispanic Black women using disaggregated hypertension data. Another objective was to adjust for the potential confounding effects of other identified risk factors on the prevalence of HDPs in non-Hispanic Black women. And my main hypothesis was that there would be a higher odds ratio of HDP diagnosis among non-Hispanic Black women who experienced racism 12 months prior to their most recent live birth. So the study population was pulled from the Pregnancy Risk Assessment Monitoring System, or the PRAMS survey. We used the Phase 8 questionnaire. And the PRAMS survey is a population-based national survey that is self-administered annually and collects information on maternal and neonatal health in women who recently gave birth. Nearly all states participate, but I wanted to limit my inclusion to states that included the racism measure of interest in their questionnaire, and those states are listed below. I also wanted to focus my study on hypertension in women who identified as non-Hispanic Black or African American. This slide details my variables and covariates. So my independent variable, or the racism measure, is a standardized question, or a standard question, meaning that it's pre-tested by the CDC and states can opt to include that in their state-specific questions. And it reads, during the 12 months before your new baby was born, did you feel emotionally upset as a result of how you were treated based on your race? The main outcome is hypertension. However, I mentioned disaggregating them. So any hypertension is defined as chronic or new hypertension, and new hypertension is specifically gestational, preeclampsia, eclampsia, or a new onset of hypertension during pregnancy. And then here are some of my covariates, or all of my covariates listed. My statistical analysis began with identifying my study sample. So from the about 250,000 respondents to the Phase 8 survey, a little over 49,000 were non-Hispanic Black. And of that group, 13,000 responded to my racism and hypertension measures of interest. For all of my covariates, there was 5% or less missing data, so that was really helpful. In describing my study sample, I calculated percentages of maternal demographic information or maternal characteristics and calculated the percentage of the independent and dependent variables by state. Lastly, I ran 3 models for each outcome, any and new hypertension. Logistic regression was used to examine the associations between hypertension and experiences of racism. And covariates that were significantly associated with hypertension in the bivariate analyses were included in the adjusted regression models. These covariates were identified a priori, and a p-value of x of less than or equal to 0.05 was considered statistically significant. Just to quickly present some of the maternal demographics, 29.5% of the study sample gave birth between the age 25 and 29. 35.8% had a high school education, 40.8% were obese, and only 2.7% had pre-pregnancy diabetes. So this bar graph represents the percentage of our study population that responded to yes or had experienced racism 12 months prior to their most recent birth. So states like Minnesota, Virginia, and Wisconsin had the highest percentages of experiencing racism, while Georgia, New Jersey, and Wyoming reported the lowest. Interestingly, when we look at the percentage of respondents who responded, who developed hypertension, Indiana, Missouri, and North Carolina reported the highest prevalence for both, while Minnesota, Virginia, and Wisconsin, who had the highest prevalence of experiencing racism, kind of fell slightly in the middle. Here are the results from my 3 logistic regression models. I split them on the screen by outcome, so any hypertension being on the top and new being on the bottom. Model 1 was our unadjusted bivariate models that assessed the relationship between each covariate and racism, our independent variable with hypertension. Model 2, our first adjusted model, is where I controlled for specific covariates, and the covariates I controlled for are listed on the screen, some of which being maternal age, parity, and Medicaid as insurance. In Model 3, I controlled for all significant covariates from both the unadjusted model and the adjusted model 1. Again, the covariates I controlled for each regression are listed on the slide. So some of them for any hypertension were maternal education and marital status, and for new hypertension being BMI and pre-pregnancy diabetes. For each of our outcomes of interest, you can see that there is an amplification or augmentation of the association between racism and hypertension as we continue to control for significant covariates in the adjusted models. So some key findings. I observed a significantly higher odds of any hypertension and new hypertension in non-Hispanic Black women associated with experiences of racism in all 3 of the logistic regression models. And across models, there was a stronger association between experiences of racism and any hypertension. And BMI, specifically the obese category, and pre-pregnancy diabetes were statistically significant indicators of both any and new hypertension. And even when we adjusted for or controlled for these covariates in the 3rd model, there was a significant association between experiencing racism and hypertension. Some of the limitations of this study, again, I was only able to analyze the desired independent and dependent variables in 11 states and New York City. So the lack of the nationwide inclusion of these measures kind of limited the study scope to the US as a whole. Income and socioeconomic status are important social determinants of health. that we're missing a lot of data actually in the phase 8 questionnaire. So it limits our understanding of the true association between SES and hypertension. We decided to use WIC use during pregnancy and Medicaid as a proxy for those measures, but however, we still don't know the true association. Again, in the same vein, the racism measure was limited to the 12 months before pregnancy and is quite a vague measure. We don't really know if we're measuring individual racism within the healthcare system, or even how upset respondents felt by the experience. So although it's useful and necessary in establishing a preliminary association, we really don't know about chronic racism or discrimination across the life course. Lastly, PRAMS is a self-reported survey. So we risk recall bias in respondents needing to remember that, that year before their birth, which was possibly a traumatic birth. So this could threaten the validity of the association we saw between our independent and dependent variables. In conclusion, feeling upset due to experiences of racism was significantly associated with an increased odds of hypertensive disorders of pregnancy in non-Hispanic Black women. And future work should explore racism as a life course stressor to inform methods of HTP management and decrease HTP mortality in Black women. I would also like to add some context to this work in our current political climate and the importance of national surveys like PRAMS. It was very difficult for me to access the data back in January after the executive orders of restricting gender-related information and DEI. So another future direction would be to create policy action to reinstate data sharing of questionnaires like PRAMS and include core questions that disaggregates data by race, sex, and gender for the promotion of Black maternal health. Before I end, I would like to sincerely thank Dr. Gemmell, my reader, Dr. Jeffers, and Dr. Powell, who have been amazing mentors at Hopkins for me, the PopFam department, and my family and friends. Thank you all so much for your support. And thank you all for listening. Are there any questions?
Excellent job, Aris. This is clearly a very large project. So great to be able to work with such a large data set and do such important work. So thank you. We have several questions already. Terry, why don't you go first?
Yay, congratulations, Aris. It's so good to see this. I was wondering, and I could have missed it because I was not looking as closely as I should have. Did you or could you stratify the sample by state or control for state in the analyses, given what we learned on the earlier slides?
I did not stratify. I did not control for states. No, I didn't. That's a good.
We actually, Aris, we did, but
okay.
Yeah, it's just not we said state fixed effects. That's what that means. But
thank you.
Yep, that was the question. And did it not? So I didn't see that as significant. Did that not matter? Because it seemed to matter earlier, but I guess it didn't matter in the adjusted models.
Go ahead, Dr. Gemmell.
I don't want to. Well, sorry, I did that part. So, the state fixed effects, there's definitely still variation by state, but yeah, it doesn't. The relationship persists after you adjust for them.
Okay.
Differences.
Thank you.
Great. Cynthia, do you want to go next?
Sure. So I think a great use of PRAMS data to really shed light on an area that we know to be true, but we often don't have data on in large samples. So I appreciate your sharing sort of the limitations of the SES measures, but actually, while a lot of births do qualify for Medicaid, it still is a reasonable proxy, and you also had WIC data, which I appreciated. So I guess my question for you is how should we all be making, so it's not really related to your essay, but something we're all thinking about, which is, how should we collectively be advocating for the continuation of these surveillance data at a time when whether it's this or other surveillance data are all hugely threatened? And what advice would you give to all of us, to make the case for this? And I'm thinking about for the Women's Health Initiative, when the funding was pulled, the community came out with huge anger and data to say why the initiative had made, such investments. And I could imagine that we might need to do something similar for PRAMS, but I don't know if you have any thoughts on that.
Yeah, I do have thoughts. I think, firstly, studies like this and data within PRAMS is really important for defining an initial association. So even though it's necessary, but it's not sufficient. Like we need the quantitative and the qualitative. And so, I mean, when we're looking for data and statistics that prove that this is an issue and public health problem, we really do need national surveys that are looking at all of these different measures. And so advice, I would just say, maybe speaking from the community and bringing advocates from the community and sharing like that this is an important issue. In one of my classes for preventing infant mortality, we talked about how states, may still continue to do the PRAMS survey, but nationally it's really important for defining those trends and, like you mentioned, gaining funding for important projects for maternal health issues. So thank you for that question.
Thanks very much. And hopefully all of us won't be asking that question next year, right?
Hopefully.
We're just about out of time. Emmy, is your question quick?
Yeah, it's just a quick point about states. You might compare your distribution of characteristics to like national data. You had sort of an interesting range of states. And so,
yeah.
And the percentage of pregnancies that occur in those states. And that at least gives some sense of the generalizability issue. That's it.
No, thank you.
That's a great point. All right, wonderful job, Aris. I wish we could keep talking about this. There's a question for you in the chat, and I saw that Nalene also had her hand raised. So if you want to put it in the chat, feel free to answer those. But wonderful, wonderful job.
Thank you.
All right, we have one more left. This has been a great session so far. So our last speaker is Yang Pei. So Yang has her Bachelor's of Science in Global Health and Public Policy from the Duke Kunshan University. And Yang's presentation is on the association between area level physical environment exposures and female reproductive development and aging. And this is a systematic review. So got a great overview, lots of different methods today. So go ahead and get started.
Thank you, Erin. So good afternoon, everyone. Thank you for being here today. And my name is Yang Pei, and today I'm presenting my master's essay titled Association Between Area Level Physical Environmental Exposures and Female Reproductive Development and Aging, a systematic review. So I want to express my special thanks to my mentor, Professor Allison, for guidance, the PFRH department, and the Hopkins Population Center for funding this project. You can refer to this table for a brief overview, and these are some abbreviations that I might use in the slides. Female reproductive function is shaped by a complex interaction of hormonal, genetic, and environmental factors. While individual level and household level risk factors have been well studied, the broader impact of various area level environmental exposures remain less understood. These environmental conditions may influence reproductive health both biologically and through social pathways like stress and healthcare access. So recognizing this gap, my project is systematically reviews how physical environmental factors at the area level affect female reproductive development and aging, offering a broader perspective on women's health across the lifespan. Regarding methodology, we followed the PRISMA guidelines and used Covidence to manage the review process. Firstly, a systematic search was conducted on January 6th this year on PubMed, Embase, Snell, and Scopus. We focused on three major themes: menopause, reproductive aging, and ovarian reserve, and aerial social and environmental exposures. We originally wanted to explore the social factors too, but considering it's a large scope of work, we decided to split it up into two reviews. An example of our PubMed search terms is in table 1 here. I used the adapted JBI manual for evidence synthesis for data extraction and assessed study quality using tools from the National Heart, Lung, and Blood Institute. The screening and quality assessment processes were done independently by two authors and finalized through discussions. So a major part to emphasize here is the predefined inclusion and exclusion criteria. Eligible studies were observational, longitudinal, or cross-sectional, and focused on natural reproductive outcomes like time of menarche or menopause, levels of anti-malarial hormone or follicle-stimulating hormone, or antral follicle counts. Only articles published in English and no earlier than 2000 were included. We specifically excluded studies which did not assess the exposures at the area level. For instance, measuring regional pollution via individual blood samples, and also excluded studies examining social environmental exposures, such as in neighborhood poverty. Articles in wrong genres and researching on wrong populations were also excluded. So after reviewing over 13,000 articles and applying this criteria, we included 16 articles. So figure 1 shows the entire screening history, and their basic characteristics are summarized in table 2. Most of the studies were longitudinal or cross-sectional studies, of which 11 were from high-income countries, 5 from middle-income countries, and notably none from the low-income countries. The most common exposures included ambient air pollution, studied in 10 articles, and residential greenness evaluated in 5 articles. Other exposures assessed included UV radiation, noise, outdoor light at night, ambient temperature, and inorganic arsenic in groundwater. As you can see, 4 different outcome measurements were used, and only 1 study was measured as fair and all others as good for their quality, due to potential limitations such as lack of sample size justification, inconsistent exposure levels among different regions, and self-reported outcomes, which could introduce bias. Now moving into the key findings. Among the 16 studies, air pollution, particularly PM 2.5 and nitrogen oxide, consistently showed adverse associations with reproductive outcomes, such as earlier menarche, earlier menopause, lower AFC, and reduced AMH levels. Green space exposure generally showed protective or neutral effects, with some studies linking it to later menopause and higher AFC. Noise and light at night are found associated with earlier menopause. Other exposures like UV radiation, ambient temperature, and arsenic had context-dependent associations, indicating more complex interactions. You can also see the detailed findings after breaking this down by specific outcomes here. If you see the AFC group, PM 2.5 exposure correlated with lower AFC, but residential greenness buffered this effect. It shows that there could be underlying interactions or effect modification between environmental exposures. Strengths and limitations are clear for this review. A major strength of this review is that it addresses an important gap in the literature by focusing on area level exposures rather than just individual factors. But including diverse reproductive outcomes, this review offers a more complex picture of how the environment impacts female reproductive aging. Another strength is the geographical diversity of this study. They cover high and middle income countries across North America, Europe, Asia, and Australia, and use both large cohort studies like the Nurses' Health Study, the second, and the clinical populations like oocyte donors. Most studies used solid designs and adjusted carefully for important confounders like age, BMI, socioeconomic status, behavior factors, and individual health conditions, making the findings less biased and more generalizable. That said, there are still some limitations to keep in mind. First, the review only included English language studies from 4 databases, meaning studies meaning that studies from low-income countries might be underrepresented. The sample size, while decent, is not large enough to be nationally representative. And the repeated use of data sets like NHS second could limit the generalizability. There was also considerable variation in how exposure and outcomes were measured, like different definitions of air pollution or different ways of assessing menopause, making it harder to directly compare results. And that's why we didn't conduct meta-analysis in this review. Some studies also rely just on residential addresses for exposure estimate, without factoring in people's mobility or time spent indoors, which could cause misclassification. Temporal mismatches were also apparent due to limitations in historical monitoring data. Finally, very few studies looked at how genetics, behavior, or social factors might interact with environmental exposures. And the limited number of long-term studies make it harder to draw strong causal conclusions. These findings actually highlight a clear need to better connect environmental epidemiology with reproductive health research. For instance, urban greening efforts and stricter air quality regulations could help protect women's reproductive health by slowing premature ovarian region. Moreover, identifying critical exposure windows, such as in utero childhood or the perimenopausal period, may allow for more targeted public health strategies and community-level interventions. In clinical settings, fertility specialists could consider not only individual behaviors and medical history, but also contextual exposures when evaluating conditions such as diminished ovarian reserve or premature menopause. In conclusion, this systematic review provides compelling evidence that area-level physical environmental exposures significantly influence female reproductive aging. Air pollution emerged as a consistent risk factor, while green space appeared largely protective. However, the complex and heterogeneous nature of these relationships emphasizes the need for future research that is longitudinal, multi-exposure, and geographically inclusive, especially in low and middle income settings. And we plan to start from the area level social factors to help finalize the puzzle. Ultimately, collective efforts between public health researchers, environmental specialists, and urban planning policymakers can make more equitable public health practices. So that's all for my presentation today. Thank you for listening. These are my references, and I'm open to your questions.
That was phenomenal. It's such a great thing to be able to do a systematic review and present it in 10 minutes. It's pretty amazing to accomplish that. So we have a few final minutes for questions. Does anyone have any questions about the systematic review? Here's your timer. Oh, less than 10 minutes. Farah, do you have a question?
Yeah, this was an amazing presentation. I can't believe how much work went into it. So great job. And I agree, presenting it in a short period of time is very difficult. So well done. You mentioned in your strengths and limitations that many of these studies adjusted for SES. I was wondering if you could speak a little bit more to that. Was it pretty much like a standard practice that all of these studies accounted for neighborhood level SES, or did they account for individual level? Or was there some variability there?
I think many of them are adjusted for individual level SES. I think just few mentioned the community level SES. So that's also a good question to measure and also like fix for the future research.
Yeah,
maybe.
absolutely. That's really interesting.
Yeah.
First thought was that with some of these associations, are we seeing that it's confounded potentially by neighborhood conditions, especially when thinking about these environmental pollutants? To what extent is it socioeconomically driven versus the actual pollutant that or toxicant that's getting into women's systems? So thank you.
Yeah, that's really a good question.
Definitely. Allison, you have a question?
Yeah. In the remaining time we have, so you reviewed these 13,000 abstracts. I helped a little bit, but you did a lot of it, or most of it. And we decided to split up into the environmental physical exposures and environmental social exposures. So if you could just share a little bit about what those social exposures are going to be that you will look in the future for a separate review.
Oh, okay. So it's like I mentioned, like community deprivation, neighborhood poverty, like that. So I think that's also a great topic to dive into, since it's like neighborhood level or regional level, and I think it's really like we really lack in that data for the research right now. And while I search for the articles, I think it's interesting to look at two specific aspects of factors like environmental, but also some articles combine environmental and social factors. They include physical exposures, but also some community level social factors. That's a great work, I think. And that's what we want to achieve in our systematic reviews.
Wow, so you're doing a second whole systematic review on that topic? That's amazing.
Everything's been screened. Well, but then it's the work, yeah.
Wow, really impressive to accomplish all of this through your master's essay. So maybe one final question, if anyone has anything burning to ask about the systematic review. Wow, well, wonderful work, everyone. So today we heard a qualitative study, a quantitative study, a proposal, and a systematic review. So there's such a diversity of approaches that our students have used, and they all just did a wonderful, wonderful job. So thank you for kicking us off on the first of our 3 weeks of master's essays. And we appreciate everyone joining us today, and please come over the next 2 weeks as well. So have a great day. Great job, everyone.